start. So, hi everyone. Thank you for the invitation, Spencer, Lauren, and Becky. It's great to be spending time with you all again. And like several years ago when I was on campus, I would like to talk about like 3 projects from my research about disease modeling and machine learning. So these recent projects have been great collaborations with my colleagues from like various institutions in the US and resulted in publications in high impact journals. This paper, the first paper, which is about identifying the effect of school closure policies to the transmission of SARS-CoV-2 virus, is published in Nature Medicine a couple of months ago. Second paper is about quantifying the effects of social distancing measures to manage the public health measures to COVID-19 pandemic, and it's published in Decision Support Systems journal. And the third paper is about quantifying the impact of mask mandates to the transmissions of the SARS-CoV-2 virus. And this is one of the current working papers. And let me start with the first one. As we all know, in the COVID-19, early in the COVID-19 pandemic, many counties around the country decided to close elementary and secondary schools along with others to in-person education. This decision was partly because guided by data extrapolated from influenza transmission models, which suggested primary and secondary school closures as an effective measure for controlling community spread. And school closure policies were also based on like early evidence suggesting that non-pharmaceutical public health interventions, including school closures, were associated with improved control of COVID-19 outbreak. But do school closure policies really work to reduce the incidence rate? So the main question we want to answer simply is, did school closures help in reducing the number of COVID cases or deaths? We observed that like different states and even counties within states employ different school closure policies. According to the data we obtained from a company called Burbio, we would like to leverage this variation between counties to quantify the effect of school closure policies on the number of COVID cases. This map shows different school closure policies employed in different regions in the US. Here we have 5 regions. The green color represents counties with virtual school mode, when the schools open for the new academic year around September 2020. For example, West is mainly virtual schools, and the red color represents traditional school mode. And in the South, especially in Florida, many pockets of traditional school mode are observed. Finally, the blue blue dots represents hybrid school mode. In the Northeast region, around Chicago, counties with hybrid school modes are observed. For our analysis, we enhanced our school closure data with 3 other data sources. First, we use CDC and New York Times COVID-19 tracker about case and death numbers for each county. Second, we use a data set compiled by researchers at Oxford about like community level mitigation measures for each county in the US. Third, we use Google mobility data to capture the mobility patterns for each county, along with basic demographic information for each county to control for possible confounders. Here in this table are some descriptive statistics from our data, broken down for each region. Among the included counties, 103 were in the Northeast, 41 in the Mountain Division, 124 in the Midwest, and 191 in the South, all shown in Table 2. The traditional full in-person schooling was the most common mode in the Midwest, and in the Northeast, hybrid learning models dominated, and in the South and Mountain Division, virtual learning was the most common. And since there was no variation in the West region, that's all virtual school mode, we excluded that region from our study. Initial school opening dates varied, but ranged from an early start date of like late July, around September 22nd and 2020, to a latest start date of late September, and significant demographic differences by region were identified. So we performed multivariate Poisson regression with event study framework as an extension of difference in difference models. Events for our data are starting of the academic year, and different counties can start at different weeks. Event study framework takes advantage of this variation by aligning the start week of each county temporarily, so that week zero represents the first week of school in each county considered. And based on our regression model, after controlling for case rate trends prior to school start, state level mitigation measures and community activity level incident rates were not statistically different in counties with in-person learning versus remote school modes in most regions of the US. While for Northeast and Midwest, the effect of school closures are non-existent, in the South, there was a significant and sustained increase in cases per week among counties that open in a hybrid or traditional mode versus remote. And these graphs are baseline are remote school mode, with weekly effects ranging from like 9 to 18% additional cases per 100,000 people. To summarize, in our case, to identify the effect of school closures to community incidence rate during COVID-19 pandemic, we find regional variation in the South, which tended to have more limited community level mitigation measures. Thus, in hybrid or in-person schooling is associated with increased community incidence rate. In the Mountain Division, although hybrid mode shows association with increased community incidence rates, when we performed sensitivity analysis, these effects were insignificant. In other regions, similarly, we observed no significant difference between school modes. Second paper, I would like to talk about the decision system powered SEIR models. I know the world-class experts of this topic are in this call today, and Lauren and her team have published similar work in this area as well. In our work, we studied different population dynamics of rural versus dense regions as it relates to COVID-19. And one way to model this difference is to use empirical R-naught value for each region. Once we have these, then we can use SEIR models to estimate disease dynamics locally. Specifically, first we show how empirical estimation of R-naught value differs for two different states, New York and Nebraska. Second, we developed an age-structure compartmental model for simulating disease spread in order to demonstrate like variation in observed outbreak characteristics. Third, we studied the effectiveness of social distancing measures in communities with different population density. Similar to their work, we have an age-structured SEIR model with 3 age groups as young and elderly have been affected differently by COVID-19. And using these models, we want to help policymakers make decisions. Specifically for policymakers, there are like at least 2 crucial decisions to make. First, when to start social distancing, and second, how long should it last? To answer the first question, policymakers may look at prevalence, and that's the percentage of cases. For the second question, various lengths are possible, and these of closure duration considered in our analysis are ranging from 1 week till 24 weeks, which are coupled with different prevalence-based triggers. Empirically, we show these disease dynamic is different in rural versus urban areas. This has immediate implications to social distancing policies. And we can model this difference with R naught in these models. These lines correspond to different R naught values. A yellow high transmission, red medium, and blue low transmission rates, representing how aggressive the disease will spread. And peak timing and magnitude of the pandemic depends on R naught values. Blue line corresponds to rural. Again, the yellow line corresponds to urban areas. As we implement social distancing, let's say 16 weeks, we see that timing of the peak delayed. So the same policy should not be implemented to all. Apparently, one size doesn't fit all. This figure compares the hospitalizations for early and late trigger scenarios for 8 weeks and 16 weeks of closure. Obviously, if you have a late trigger, you will observe like first wave in a large magnitude, as shown in figure A and B. However, the magnitude of the second wave is smaller in late trigger than early trigger. And the timing of the peak is about the same when social distancing is implemented for 8 weeks. To further push the timing of the peak, we may consider social distancing for 16 weeks. For example, in our scenario, 16-week closure pushes out the second peak more than 100 days away. And to control rapidly growing outbreak across US, like public health officials and governments issued shelter-in-place orders. Although social distancing and shelter-in-place orders like help mitigate the outbreak, it has significant economic and social costs. For example, in the US, during social distancing, the unemployment rates have spiked. To identify possible reopening strategies, we evaluate a two-phase reopening strategy. We compare this strategy to two basic alternatives, no closures and immediate reopening. In reopening with phases, we start with full closure of 8 weeks, following by phase 1 and phase 2. In phase 1, we increase contact rates about like 60% of initial contact rates with no restrictions. And in phase 2, we increase contact rates to 80% of initial rates. And finally, we open fully, restore like 100% of initial rates. This graph illustrates with reopening strategies, you couldn't only delay the peak of the outbreak, but also reduce the magnitude of the peak a little bit. And now let me move on my third and final topic. I would like to talk about our working paper on estimating the impact of mask mandates on reducing the number of cases of COVID-19 incidence rate. And for our analysis, like before, we enhance our data with the following data sources. First, we use CDC and New York Times COVID-19 tracker about like case and death numbers for each county. Second, we use Google mobility data for each county. Third, we use a data set compiled by researchers at Yale about community level mitigation measures for each county. And we use risk level data from COVID Act Now, which provides the risk level over time for each county. And finally, we use Google mobility data to capture the mobility patterns for each county, along with basic demographic information from each county to control for possible confounders. Very similar to the first project I'll talk about, we performed multivariate Poisson regression with event study framework as an extension of difference in difference models. Events for our data are mask policy changes now to mandate and to recommend it. So different counties can make policy changes at different times. So event study framework takes advantage of this variation by aligning the start week for each county temporarily, so that 0 represents the mask mandate issue week in each county and level of risk at that county for at that week for that county. So,
and Zeynep, is this all the counties in the country, or is this part of the country?
It is kind of like all. We are using more than 2,850 counties, and it's like it's very. It's, I think, around 90% of the counties, because some counties doesn't have data, and some of them does not issue any mandate or recommended policy. So we are excluding those. We are just looking at the mandated and recommended mask mandate counties. And we are comparing counties with mask mandate to those without mask mandate, but it's like kind of recommended policies. And for low and medium risk counties, after policy change for the first 10 weeks, mask mandate implementations, no significant effect. I'm gonna do a quick summary. For all of the risk levels, the regression coefficients show a similar trend. Within the first 10 weeks after the mask mandates, no effect is observed. After 10 weeks, regression coefficients are significant and negative, suggesting the counties with mask mandate correlate with fewer number of cases per capita. And besides this, I'm also working on association between pandemic school mode and change in body mass index percentile in school-age children. So our aim of this study was to measure the impact of school learning model, either traditional, in-person, remote, or hybrid, on change of BMI percentile in a longitudinal cohort of like pediatric patients during 2020-21 academic year. And we are also looking into mental health of college level students by comparison during and post-COVID era, looking at their physical activities and like their mental level illnesses by a survey. And thank you so much for listening. I'll be happy to answer any questions.
Thank you, Zeynep. That was really interesting. I'd love to dig into all of those. I'll start by asking one question, and then, I'm sure others have questions as well, but got to decide which one I talk about. So let's talk about the second paper, which definitely, resonates with a lot of what we've been thinking about. Just at a very high level, I'm curious, it was published in 2021, but I'm curious about kind of the context in which you developed the model. What is your, have you talked to policymakers, or what are your thoughts about how to translate those results into either previous policies, or sort of going forward, but just a little more about the context and application of it?
Yes, so application is like, it was like, we were using early stages of like COVID-19, and it's like back then around 2020 and 21, the social distancing policies were in effect, and it definitely captured a lot of attention, and we were like talking about local public health officials in the upstate New York about like social distancing policies, and like around the campuses as well. And you did amazing work, U2 campus studies. I was like following those as well. And yes, for the early stages, like social distancing helped a lot. Social distancing policies helped a lot. And I think we, like as US, we took advantage of that social distancing, and like preparing ourselves for worse times, I believe.
And in general, what do you think? I mean, in the analyses that we did that were sort of very similar in spirit, we never really considered these sort of, or maybe we did, I'm forgetting, these sort of fixed duration closures. Rather, we were looking at trigger open, trigger close. What do you think in general? And I don't know if we've done any retrospective. What if we just had said every time? And although I do remember early conversations where the mayor said, if we go into a lockdown, can we promise the city will be out in 4 weeks or something? Or if we go to a lockdown earlier, can we promise the city it'll be a shorter lockdown? What do you think in general about sort of fixed duration closures versus more data-driven, data-driven openings?
So it depends on the capacity of like hospitalization capacity and ICU capacities, I believe. So in this graph, for instance, if we like use an early trigger level, and this I'm going to show with my arrow if I could find it somewhere. I can't find it, but the first, like in graph A, 8 weeks of social distancing, the first wave was like comparatively really small compared to like 8 weeks of social distancing. And if we have capacity around for the second week, I believe, like personally, we could use that capacity to evenly distribute. If we are not using any vaccination or any other public health interventions, social distancing might give us some opportunity to use our capacity fully. So using an early trigger versus late trigger might benefit us more, I believe. And but it's very dependent on the region and the capacity of ICUs or hospitalization capacities. And it might give us some time for the vaccination. And I think like 16 weeks of social distancing gave us like around 100 days of days like extra for the peak. And in the meantime, we could like prepare ourselves and find other sources or like other pharmaceutical interventions may come handy after some time. So I believe we could leverage these differences in between, and this is all empirical. And I believe we could right now, if we are comparing right now with testing and vaccination. We are including those in our model, and we are seeing that testing and vaccination levels, we could find a Nash equilibrium somewhere to find a good point, so that like some people will not like vaccination, and like if we do extensive testing, we could get rid of like large magnitudes of or surge of patients in the long run.
Thanks, Zeynep. Other questions from the group?
Hi, yes, this is Jennifer Johnson-Lung. I was wondering about the first study. You said that you had some regional variation, and I was wondering if you had any hypotheses for what was the sort of driving the difference between what you saw in the regions in particular, if you had hypotheses about why the school closures or the virtual school seemed effective at reducing transmission in communities in the South, but not in the other regions.
So it's like, for instance, for the West, that's a good question. For the West, we are not seeing any changes, and we are like excluding that from our study from like it's all virtual school mode. And other parts of the country, so we could like compare regions in itself, so that we are looking at all possible confounding effects. And I think I forgot your question, Jennifer. Can you repeat it?
If you had any hypotheses about what was driving the effectiveness in the South.
Oh, yes, South. So I was thinking that maybe in the South, South like as a whole, it's like a huge region over here. We are including Florida, Texas, and everything. And we see that like maybe other mitigation measures may not have been used effectively, like masking or social distancing. And we see that there is an effect, and I think there is So it's like compliance factor might have an issue in South.
Yeah, thank you.
Zeynep, on this study, I was wondering if you, or if your thinking has changed overall since, so these data were the fall of 2020, right?
Correct. Yes.
So I was wondering if you're thinking or if you've done any updated analyses that suggest any different conclusions about school reopening since then.
We don't see much variance right now this school academic year. So we were thinking that maybe redoing everything, all of the study for this academic year, but we don't see a lot of variation. So most of the schools went back to traditional school learning mode. So a comparison will not be fair.
There is some variation in mask requirements in schools. I don't know if you've looked at that, but that could be.
Yes. So right now, the third one, we are including like mask requirements overall in the overall community, not looking exactly for schools, but overall community. We are using that variation.
Casey, do you want to ask your question?
Yeah, I just had a quick question about the study design. So you briefly mentioned a diff and diff study design to estimate the effect of the policy. I guess my confusion there is like, with a traditional diff and diff, you want just a single intervention at that like point where you're taking the pre and the post measures of whatever we're looking at, like cumulative case counts, right? To get the unconfounded estimate. But here you could have like school closures could coincide with a bunch of other intervention measures that are occurring contemporaneously in that like specific time slice that you're defining as the cutoff for the diff and diff, the pre and the post. So how are you disentangling like these sort of, like, for instance, when school closures closed down in 2020, people also stayed at home, right? People also like locked down. And so a diff and diff design there would confound the estimate of school closures and lockdown because they happened exactly at the same time. How are you disentangling that to make a claim about the marginal effect of school closures?
And that's a great question. So we are using diff and diff for we are also including Oxford data. And in that data, the other policies are included. So we are saying that it's fixed effect model. It's like we are keeping those other policies fixed. What is the school mode change? And traditional is the baseline. We are not using pre-post. We are using traditional as a baseline and looking at virtual hybrid difference with traditional. Does it answer the question?
Yeah. But that means you would have to find locations that held the other Oxford variables constant and only had a school closure change in that specific time range. Is that true?
Yes, kind of. We are limiting our study for like September till late December, just for that reason. We don't want to have other effects or traveling factors, just by school mode, how it's like helping or not helping at all. That's why our time is limited.
I see. Thank you.
Sure.
So that about this study, and I think I saw it and read it, but I'm not remembering the details, and I look forward to reading it. But I recall that maybe it was around the same time you did your study or early that the CDC came out. I mean, it was based on your study and said school openings don't aggravate risk in communities, and so this was part of their kind of motivation for recommending that schools reopen in the 2021-2022 school year, or maybe it was even earlier, I can't remember. And one of the former postdocs from the lab sort of took a look at the data they were looking at. And in particular, there was one study from some community in the Midwest. And she concluded that there might be sort of, and someone correct me if I'm replaying this incorrectly, but she concluded that there might be sort of a bias in how they're looking at it, because you wouldn't necessarily, what was it? You wouldn't necessarily be able to detect if schools were amplifying transmission because of the lower detection rate among children, because children were more likely to be asymptomatic and less likely to end up as a reported case. Mm-hmm. And I'm forgetting the details a little bit, but is this something that you considered or came up in your study, was kind of differential reporting rates based on age, and that might sort of potentially bias what you see in the data?
There might be, but over here we are using the community case rates. So we know that school-age children might bring the disease at home and spread through the family. So that's why we are looking at not by the age difference or incidence rates for the school-age children. We are looking for the whole community incidence rates and seeing if it's affecting overall community.
Yeah, and I noticed that one of your co-authors is Emily Oster, right? And she's been a very big proponent of keeping schools open as much as possible, right? And very concerned. Was this particular study sort of instrumental in kind of communicating to CDC or policymakers that schools should be opened? I'm curious about how this study played into decision making after it was published.
No one reached out to us after the publication of this work, and from CDC and or WHO. So I don't think it's a common it affected their decision very much. Because they decided when this was published around October, the schools were already open.
Yeah, mm-hmm. Right. And it was, and this is a comparison of virtual and hybrid, and many of the schools went back to traditional, right? Which is not.
Yes.
Which is okay. Mm-hmm. Yeah, interesting. Was this surprising? Were the results just surprising?
For me, yes. I was expecting the other way around. I was expecting that traditional school mode was increase the community incidence rate, and I wasn't expecting this kind of result at first. But yeah, so science is science.
Yeah, that's right. So I'm curious about, I can't remember, I think this was number 3 now, and someone else jump in if you have a question, but 3 was the one where you used the Yale policy data, right?
Yes.
And I'd love to know just a little bit more about what's contained in the Yale policy data. We've done some work in trying to collect county level data in Texas, working with the Oxford Policy Response Tracking Program. And it's been, we've had a lot of undergrads working on this, and it's been really challenging because the data are not clearly, not available in similar format, different things, So I'm wondering if you just tell us a little bit about this data, what's available in it, where we can find it, et cetera.
Yes, so this data includes all policies and their start dates, end dates, if they are switching to mandate to recommended to mandated again. It's collecting all of the components, mask components, and even mask. It's residents in and out mask, residents business mask mandates or business closures, employee mask mandates, business 25% level of capacity opening, 75%, 50%, all levels of policy data are included in this study. And it's a very comprehensive study, and they improved the data like a couple of times. They were like looking all of the counties in the US, around like 3,000 counties in the US are included in this study. And so almost all of the counties. And I could say that maybe like only 2 or 3% of the, we compared by hand, we were like comparing by hand, like randomly selecting those counties and looking at if the policy for that county is correct or not. We were like double checking if it's like, if there is any issue with it, and we didn't find any issues.
Do you know how they collected that data? I mean, did they go to the websites of each like county health department, look in newspapers? How did they?
Yes, I will send you the link. They have a paper published in this. So they published a paper, a business school professor, Matt, I guess, I forgot his last name, but Matt
Spiegel.
compiled all of, yes. He compiled all of the data at county level, and he and his team published it. So I'm gonna send that that link to you so that you could take a look, and it's very comprehensive.
Does it? So are you familiar with it, Spencer? How does it relate to the Oxford data that we've been collecting?
No, I just looked it up
Okay.
since Zeynep mentioned it.
Okay, very interesting. Oh, that sounds like a great data source. So, and remind me, so this is the one where you're looking at the mask and yeah, oh yeah. So I remember the question I had for this one. Mm-hmm. So you found that there doesn't seem to be an effect in the first 10 weeks after the mask mandate, and then there is an effect in the direction you'd expect. Mm-hmm. I find that kind of surprising, you know, like why, and what's your interpretation of that sort of delay? And do you think that's a real signal that, you know, almost over 2 months later, a mask mandate is slowing transmission?
So again, the study findings are very surprising to us. I wasn't expecting, because we were working with MDs from Harvard, and they were telling that mask mandate should be in effect within 8 weeks. And after that, maybe some other kind of like measures are in effect. And we see this effect after 10 weeks in almost all of the risk levels. Basically the first couple of weeks, there is no effect. And the we are comparing mask mandate with mask recommended. So we are not comparing with no mask, but mandation, mask mandation policies. So apparently, like for low risk and medium risk counties, we don't see an early effect at all, but like high risk and critical regions, in the first couple of weeks, we see a mild effect. And we could say that it's not like the mask mandate shouldn't be a mandate for all of the regions.
So sorry, I'm looking at this graph. So are you saying like, is a positive value mean that the masks are slowing transmission?
Oh, I'm sorry. It's a positive value. It's not slowing. It's like increasing the transmission in the first couple of weeks, and after that, it's like decreasing effect. I'm sorry. I confused myself. Yes, it's a positive value. So it means that it's increasing the transmission between, and there might be some kind of like compliance factor again in the first couple of weeks for high risk and like critical regions. Mm-hmm. And again, we are like looking in difference models. So we are quantifying the effect of the mask policy, like in the overall compared to like all of the factors fixed.
I think one of the problems here, though, is that you're not fixing, because you can't fix the case rates by week, right? So what, like my explanation for this plot would be that this is confounded with the natural decline of the epidemic wave. And so when you look at week 10, there's already a natural decline in cases, and the diff and diff is artificially picking that up because it can only explain it through the mask mandate. Or sorry,
So-
through the mask mandate.
Yeah, it would be true if we are not fixing the mask mandate start date for all of the counties. So right now in this study, we are shifting all of the counties weekly effect to week 0. Let's say that County X is issuing a mask mandate on like May 2020. And County Y is issuing the effect of mask mandate August 2020. So we are shifting all of the counties to week 0, that week of mask mandate. If we haven't done that, like shifting, your theory would work. But over here, we have a wide variation among the counties.
So I agree that the shifting does help alleviate things a little bit, but still mask mandates are put in place and lifted with respect to the epidemic curve. The shape of the epidemic curve, right? Like people implement mask mandates when things are growing. And since things will then naturally decline, you still have some, in my opinion, some residual confounding here of time here, where it's like time since, start of wave, right? When a wave starts, a mask mandate's going to come, it's going to peak, and then it's going to naturally decline.
True,
Sorry,
it might be true, yes. So, yeah. But we are looking at different risk levels. So we are dividing the country in different risk levels. And I think this study might be fixing those risk level effect as well. So low risk and critical risk, their start dates. So if we look overall US, your theory would work, but since we are dividing into different risk levels, I think, and risk level is based on vaccination, community case rates, increased rates, and let me find 3 other factors more. So from COVID Act Now website, and basically we are trying to find that effect as well.
Yeah, I think this it's a little, I think when you write this up, besides considering these confounders, it's a little bit concerning to come out and say that masks actually increase risk in the first few weeks, because it's probably not, even though that's what you're showing in these bottom graphs, right?
Yeah.
But that's probably not actually a causal thing, right? So I think I would just say, want to make sure not to send the wrong message, right? And right, and that you have to wear masks for 3 months in order for them to have an effect, right? That's kind of, it's a little counterintuitive.
Yes.
Yeah.
True.
But interesting. And remind me, what was it you mentioned very quickly of what sounded like a very fascinating study, but you didn't show any slides. What was the last study that you mentioned?
BMI.
The BMI, yeah. So do you have any preliminary results?
I do have. So it's going to be a short paper. Let me try to find that, and I'll show. Let me start sharing, and I'll show that couple of graphs. Oops. For some reason, my arrows. Oh, maybe that's fine. Okay, let me find that. And in the meantime, BMI. Sorry, I wasn't prepared for that.
Oh, that's okay. I mean, I'm just curious. Maybe if you don't have a graph, I'm curious. I mean, are you seeing that being at home is correlated with higher BMI? Like that, do you find evidence that the kids became less healthy?
We were expecting that.
Yeah.
We couldn't find that one either. So So we were expecting that their BMIs, because when you look at like without difference and difference model, like if they are changing or not. Let me find that. So there is still, it says still ongoing model, but we have a couple of early results.
So while Zeynep looks for those files, I just wanted to mention, for those of you who haven't heard, today is going to be Woody's last day with the consortium. So please make sure to wish him farewell today if you've interacted with him. And I guess he dropped off already, probably with the time, but please feel free to send him your well wishes before he goes, although I assume he's not going to instantly sign off of Slack, so you probably don't need to get those in. And then we also wanted to announce that today is Lauren's birthday, so please send her a birthday wish as well.
Yes, for those of you who are curious, this is the first day of my 50th year of life. So
Happy birthday.
Thank you. Yeah.
Birthday. That's exciting.
Thank you. Yeah. It's sort of confusing. I was thinking about that. I actually, it's my 49th birthday, but I'm actually entering year 50, right? Today. Ah, crazy.
Only, you don't get to be a square that many times in your life. So you're a square for a whole year.
Oh yeah, I'm a square. Yeah, that's great. Thank you, Spencer, for announcing that. Yeah. Okay, Zeynep, if you,
I found one.
Oh, you did? Okay, great.
Yes. So
Love to see it.
one.
Okay, wonderful.
Sorry, it took me so long.
No, that's okay. We put you on the spot here.
Thank you. So we are looking at elementary, middle, and high school kids, and we see remote, hybrid, and traditional school mode, and the light gray ones were pre-COVID time period, and dark ones are from COVID-19 time period. And right now we are doing this for after COVID-19, so like late COVID-19 period, because we are not out yet. So we see the significant ones were starred.
Are these, sorry, is the y-axis BMI? Is that?
BMI changes, BMIs, yes.
Okay.
BMIs with remote, hybrid, and traditional. We see, so over here, between elementary school kids, we see an increase, but it's not changing like with the school mode a lot. So we see remote school mode, hybrid school mode, and traditional school mode, although we see a little bit difference in elementary school and in middle school. But in high school, hybrid kids were significant, and it's we don't see any other significance in high school kids.
That's interesting. So like in elementary school, it looks like everybody got a little bit less healthy, but there wasn't a big, just from eyeballing it,
yes,
perhaps not a big difference between whether you actually went to school or stayed home.
Yes.
That's interesting. Yeah.
Middle school kids, we are taking advantage, and we are like looking at the confounding factors, because these school age children, they need to, their percentile should increase. So we are looking at their the possible increase are taken into account. We are just looking at traditional remote and hybrid school modes difference between them.
So is this based on patient data where
Yes.
for one student, like you know whether they were remote or not, and you have their BMI before and after?
Yes, this data is collected from Massachusetts. It's how many clinics? I don't remember right now, like the exact percent of the kids, but over 3,000 students are included in this study. And their BMIs were tracked since 2018 till 2021. And right now we are like adding extra 2021 period. We are included right now. This graph includes till April 2021, and we are trying to include till this time period so that we see late COVID effect if there is any.